Today we are doing this complement deficiencies which has been tested in this year INISET exam. So before learning this complement deficiencies, we'll quickly go through this complement pathway. So here we have three: classical pathway, lectin pathway and alternative pathway. For classical pathway, we have to remember that it is activated by this antigen antibody complexes, and this activates the C1q. This activates the C1q, and this C1q will activate further C1, C1, C4, C2, which ultimately get converted into C3 convertase. And in lectin pathway, here what is happening, this MBL is binding to the mannose. So what it is, mannose is the present on the pathogens, which leads to the formation activation of MASPs, which further activates the C4, C2, and finally it is also converting into C3 convertase. And then we have this alternative pathway, which is activated with the help of these pathogens, injured tissue. Here it is forming the C3b, which is with the help of these other factors, factor B, D. This P is properdine, which is a stabilizer. This is also getting converted into C3 convertase. So now after this, the C3 will be converted into C3A and C3B with the help of this C3 convertase. So we'll learn about what is this C3A, C3B. So C3A is this anaphylatoxin, and C3B, B is opsonin. So बढ़िया खाना से we'll remember C3B, बढ़िया खाना. A is anaphylatoxin, and now the C5 is converted into C5A and C5B also, C5B. So this is converted with the help of C5 convertase, and ultimately the C5B is converting into C5B and C5B9, which is this MAC complex, and this MAC complex is responsible for this cell lysis and activation. So we'll go through this quickly through these diseases, and we'll come back to this pathway also. So basically we have to remember that most critical step here we have is C3, and final effector here we have the C5B9. So C5B9, which is MAC. Okay, so deficiencies में whenever the C1q 2 4, it will present like SLE like illness, and when there is C2 deficiency ka we have to remember this is the most common deficiency, and C3 deficiency ka we have to remember that it presents with severe recurrent pyogenic encapsulated infections with encapsulated organisms and SLE like presentation. And then we have the C5 C9 MAC deficiency. This deficiency is there, it will present with recurrent Neisseria. So we know that this is like ultimately when all this activated, there is inflammation in the body, but that is only required when there is bacteria in the body, when there is any infection, any toxin. Otherwise it needs to be inhibited. So this C1 inhibitor is required. If there is deficiency of the C1 esterase inhibitor, it will ultimately lead to this hereditary angioedema. So factor H and factor I will also study this. This is seen with alternative pathway that leads to, if there will be this deficiency, will lead to atypical HUS, macular degeneration, and also one more condition, that is this I think the glomerulopathy. Glomerulopathy is also seen here. And then we have this one more defect, that is DAF CD55-59 defect that leads to PNH, paroxysmal nocturnal hemoglobinuria. So we'll quickly go through these pathways. So buzzword for classical pathway, the buzzword used is autoimmunity, SLE like. Most common deficiency C2 overall. Association is SLE, glomerulonephritis. So we can go through this. Early classical complement deficiency, SLE like disease. Okay, so alternative mein we have to remember, like alternative, this one C3b, this factor B, D, properdine. So all this factor I also. So buzzword for alternative pathways, this uncontrolled activation or Neisseria infections. So when there is factor D, properdine deficiency is X-linked, that present with recurrent Neisseria infections. And when there is this factor H and factor I deficiency, that leads to this continuous C3 consumption and low C3 levels in the body. And the diseases with alternative pathway deficiency is atypical HUS and C3 glomerulopathy. So this is how the question can be asked. You can go through this. Now the terminal pathway deficiency, that is MAC formation, C5, C6, C7, C8, C9, and buzzword here will be recurrent Neisseria. And we have to remember, due to this loss of membrane attack complex, it cannot kill Neisseria meningitis. Patient will, so buzzword here will, one more buzzword can be used here is that patient is otherwise healthy. So exam lines will be MAC deficiency, will think about the recurrent meningococcal meningitis, and C5 C9 deficiency, Neisseria infection. Okay, so this is same, this we have, which we have discussed in this flow chart. One thing we have to remember, that everything is converted into the C3 convertase, and C3A is inflammation, is responsible for the inflammation. The C3B is responsible for this opsonization, and C5 convertase, the C5 convertase in converting into C5b9, and that is responsible for cell lysis. This we have done. Okay, now from medicine point of view, anytime in a question they have written recurrent Neisseria infection in a healthy young man, healthy young person, will think about C9 deficiency. Recurrent SLE like illness in a young patient, think about C2 C4 deficiency. Recurrent angioedema, but buzzword is without urticaria, without pruritus, and resistant to antihistamines, will think about C1 inhibitor deficiency. And any patient will presenting with dark urine in the morning, thrombosis, will think about this PNHC D55 CD59 defect. Then in pediatrics point of view, any infant coming with the recurrent pyogenic infection will suspect C3 deficiency, and child with recurrent meningococcal meningitis will suspect C5 C9 deficiency. So here from pharmacology point of view, eculizumab, we have to remember what is this eculizumab, monoclonal antibody. This is anti-C5 monoclonal antibody which we are using in PNH. This is very important, PNH and atypical HUS. So in C1, so in this condition, hereditary angioedema, what we are giving the C1 inhibitor concentrate and C1 INH concentrate and bradykinin inhibitors like icatibant. So ravulizumab, we have to remember, this is also a long acting C5 inhibitor, and microbiologica, this we have discussed already. So you can see this. So this was the question. I think this was this year question, that live vaccine is safe in complement deficiency, but it is contraindicated in DiGeorge, Biscott, Eldridge, ataxia, telangiectasia. This we have discussed. Now, okay, lab may we can see that if there is CH50, this decrease in this CH50 levels, we'll think about classical pathway defects. AH50 decrease, alternate pathway defects. This we have done. Vaccines allowed in complement. Okay, this we already have studied. Now one more thing which is left is this hereditary angioedema. We have to remember this. We know the C1 esterase deficiency ki wajah se, this is the cause behind it. The etiology is this, and patient presented with swelling. Initially the swelling will be on the face, lips, but it can later on can involve the larynx also. Okay, and one thing is there will be no pruritus, no urticaria. This is important, no urticaria, and triggers can be stress, can be trauma, and ACE inhibitors is also the trigger. And treatment, we know, we have studied in the pharmacology part, that C1 inhibitor concentrate, this B2 antac we are giving, and steroid and antihistaminics are ineffective. This we have to remember. Now this CD55-59 deficiency, so we know that these are responsible for protecting the RBCs. These are the protective covering around the RBC, which are protecting it from the attack of the complements. So if there is this deficiency, will lead to this PNH, and the triad we see here is this hemolysis, this dark urine presentation, pancytopenia, and thrombosis. And test we do here is flow cytometry, where we check the CD55-59 levels, and drug we have started, eculizumab we give. C5 C9 deficiency, the classical clue will be recurrent meningococcal sepsis, and C3 deficiency के लिए severe bacterial infections, encapsulated, especially encapsulated, and glomerulonephritis. So I think this we have covered the whole complement deficiencies in around 10 minutes, less than 10 minutes. Thank you.